I'm Ann Sales. I'm a faculty member currently at the University of Michigan in the Department of Learning Health Sciences, but transitioning to a faculty position in the Sinclair School of Nursing and Department of Family and Community Medicine at the University of Missouri, where I will be after January 1st. Today's talk is about selecting and applying implementation science frameworks, and this is in service of closing the evidence to practice gap. So first of all, I have no financial relationships to disclose. I just note that I am one of the co-editors-in-chief of one of the journals that is in the field of implementation research called Implementation Science Communications. It doesn't really pose a conflict of interest, but it is something to note. So what I'm going to do in today's talk is first do quick definitions around the term implementation, and then I'm going to do an overview of frameworks and discuss a typology. I know that in some previous sessions, folks in this group have learned about frameworks already, and hopefully what I'll be talking about will extend some of that discussion in useful ways. Then I'm going to talk about how to use the typology to guide, design, and evaluate implementation interventions. I'll be talking about process models, determinants frameworks, and evaluation frameworks. And I'll be using intensive care units as an example, recognizing that that may not be settings in which many of you participate, but the use of some case example and grounding this in a particular context can help think about how to do that grounding, and it can be applied to many other contexts. So starting off with a couple of just working definitions. My definition of implementation is that it is a process of planned human behavior change under organizational constraints. This sounds different from the definition that is used widely, and the most dominant definition, which comes from the first paper published in the journal Implementation Science when it launched in 2006. But in fact, it's really sort of a refinement of that definition. And for me, at least, it helps to make clearer exactly what the work is of implementation and how it fits into the world in which we live. Implementation science follows from that, and it's the study of planned human behavior change under organizational constraints. And then implementation practice is the process of supporting and doing this work of human behavior change under organizational constraints. I'm not going to spend much time in this discussion talking about the organizational constraints component of this. I think the behavior change part is clearer to people, and I will be talking more about that. But part of the point here is that this is what distinguishes implementation from health promotion, health behavior change at an individual level. When we're talking about making behavior changes that are about how we do things in our own lives and our own activities and our own behavior, there are constraints on us, certainly, but they're not the same kinds of organizational constraints that apply to professionals working in organizations, which is the case in most of healthcare. So most of what we do in healthcare as implementation is very much within the context of organizational structure. And when I say constraints, I don't just mean things that bind you. They can also be facilitators and things that enable you to do your work in certain ways. So I'm going to leave the definition. I'll come back to it later in our discussion. So I'm guessing that you've seen this typology on the left here. It comes from a paper by Per Nilsson, published in 2015 in the journal Implementation Science. And it's a very helpful framework or typology. I don't want to overuse the term framework from my perspective. And the place I focus generally is down here at the bottom 5 boxes, but it's important to look at all the levels. In this paper, he was really interested in understanding theoretical approaches that are used in implementation science. And then he described 3 basic sort of big buckets of ways in which theoretical approaches are used. And then he came out with 5 different types. The 3 of these 5 that we'll talk about today are process models, determinant frameworks, and evaluation frameworks. I'm not going to talk about classic theories or implementation theories. I would suggest that you read the paper if you're interested in those. But at this point, the classic theories come from other disciplines. And while we use them and they are useful to us, they don't give us as much insight to the work of guiding, designing, and evaluating implementation interventions, which is what I'm talking about today. So they're used differently in different parts of implementation work, and that's a really core message that I'd like to convey today. This is an example of a process model. I'll talk more about process models in some detail, and I'll be using this one as the exemplar. It comes from a paper published in 2019 in Frontiers in Public Health. Maria Fernandez is the first author. And it essentially takes an approach that's been in the health promotion literature for a long time called intervention mapping and turns it into implementation mapping. And there are 5 separate tasks described there, which I'm going to go into more detail about. But this is a good example of a process model. And that's one kind of model that you might want to use. Other types of frameworks that we'll talk about are determinants frameworks. Excuse me, and this little graphic illustrates what's called the Tailored Implementation for Chronic Diseases Checklist, which may not sound like a framework, but it is. And I'll talk more about its origins and its uses. But the idea behind the determinants framework is that these are the catalog of factors that have been shown empirically and theoretically to determine or influence the success of implementation when you undertake an implementation intervention. And finally, I'll be talking about evaluation frameworks. The one depicted here is the REAIM framework, which is well known to many people in this field. So one of the things that makes picking and selecting frameworks hard is that very few are actually relevant to specific health settings. So this is where I'm going to use the ICU case example for the first time. None of these 100+ frameworks that exist in the literature are specific to critical care or ICU context. They're often not specific to any other context, although there is a group of frameworks that have been custom built for mental health and community mental health settings in particular, led by Greg Ahrens and colleagues. And I think it's important to look at those, and particularly if you work in the space of community agencies, particularly those delivering mental health, substance use, and other behavioral health services, then those frameworks are likely to be highly relevant. It's not clear to me that the frameworks you choose have to be specific to the context in which you're working. They have to be adapted if they're not specific, but they don't need to be specific from the outset. And I think there also should be no expectation that any framework is going to completely describe everything you need to know. The point of frameworks, particularly the determinants frameworks, but also process models and to some extent evaluation frameworks, is that they are checklists. And that's actually one of the reasons I like the term checklist from the Tailored Implementation for Chronic Diseases checklist, that even though it is a framework, the authors explicitly describe it as a checklist. And I'll talk more about its use and its particular functioning as a checklist in a minute. The other thing I want to say is frameworks are not set in stone. One problem is they're published. And once they're published, it's hard to change them. You can't actually change the publication. You could, but that's not what we do in the peer-reviewed publication space. But we can add new elements. And I think if you look at recent issues of implementation science, you'll see that there are papers that add new elements to specific frameworks. And I think this is actually really important work. It's actually how we extend our knowledge and understanding and how we begin to use the frameworks in really productive and useful ways in the work that we do. The 3 types I'm going to talk about are all relevant. And one of the issues is that that suggests that you might actually want to talk about using 3 frameworks, which seems like a lot. And especially if you're writing a proposal for funding, may seem like too much to a reviewer. But because I argue that they're used in different ways, the different uses matter and you will use them differently. And so arguing that it's worthwhile using 3 different frameworks potentially is important. But I also want to note that there are other types of frameworks, and I think the typology that I just described, the paper by Per Nilsson, is a good example of how the field is evolving and this is not set in stone. So for example, there are frameworks that describe strategies, implementation strategies. They're called typologies sometimes, or other words are used to describe them, but they are frameworks and they're a separate type. I would not lump them in with determinant frameworks or evaluation frameworks or process models. I would say that they need to be a separate type. So there's another bucket to add to that list of 5 in his typology. There's also emerging work in fidelity and or adaptation that possibly constitutes another type of framework. My main point here is not to be exhaustive about this, but to say this is a rapidly evolving field and we should not get too fixed on any certain number of types or frameworks or anything else. So before I start talking about each of these types in a bit more detail, I'd like to just talk about how do you select a framework, because this is an important issue and a lot of people find this very complex and confusing. There's a paper by Sarah Burkin and colleagues published in 2018 in Implementation Science that describes a particular approach to finding and selecting frameworks. The dissemination-implementation.org website that Ursula Rabin and her colleagues initially put together and continue to maintain is also a helpful tool. Some of the frameworks that are out there, in particular the Consolidated Framework for Implementation Research, or the CFIR, has a very helpful website, cfirguide.org, that will help you think about how to use the CFIR. Reaim.org is another website that offers a lot of helpful guidance for the use of Reaim as a framework. I would suggest that it's important not just to use these tools, but to think about the criteria for how and why would you select any framework for a given purpose. I would argue that how recently the framework was published and how, in a sense, up to date it is, how much of the literature it embeds and embodies is important. I think this may be particularly important for the determinants frameworks, which, as I said, are catalogs of factors that we know can influence implementation success or failure. And I just note that the tailored implementation for chronic diseases is the most recent consolidated determinants framework currently in the literature. I'll talk more about that in a few minutes. But I would argue that fitness for purpose, the thing that you want to do with the framework, should be a major criterion that you consider as you think about it. And then finally, how accessible is it? Do you understand it? Can you use it readily? This is actually a really complex area because most of these frameworks are extremely distilled. They boil down very, very complex constructs and they boil them to a single word often or a very short phrase. That actually decreases accessibility, even though it makes them look accessible. You look at it and you go, oh, there's X number of words on the page here. That I can deal with that. But in fact, each of those words is like the tip of an iceberg. Underneath it, there is this vast quantity of other stuff. And I think it's really important to recognize that. So I'm going to start with fit for purpose process models. And the purpose here is to guide the process of implementation. So there are a lot of different process models. I've got some pictures here of different ones. How can you tell if it's a process model or framework? Because they frankly don't come labeled or tagged at this point. One of the papers that I asked the Learn Network to put into the materials for this session is the most recent systematic review of frameworks. Rachel Tabak is the lead author. It was published in 2012, so it's actually quite dated by now. It doesn't actually distinguish between these types of frameworks. It does give other important useful information, but I would argue that you can tell that something is mostly a process model if it has steps or phases to it, if it provides direction about how to move forward, and recognize that these could be linear steps, or they could be circular, or they could take some other shapes and forms. Some of these are circles within circles. There are all kinds of different depictions. I've got a couple up here that you might recognize. This is the PDSA cycle, and it's commonly used in quality improvement, not very often used in implementation research or implementation work, but I would argue that it has a lot of utility. This is an A3, and I would argue that the A3 is also a process model. It actually gives you steps and phases to follow and to complete. And then finally, the implementation mapping process model, which I'll talk more about in detail. And I just want to acknowledge that, particularly for those of us who do work in the VA, a recently published guide called the Query Roadmap is actually very useful. And I would argue, again, is a process model. If you look at it, there are steps from pre-implementation through implementation to sustainment. There is a direction to the steps and clearly lays out steps and phases to follow. Implementation mapping is also step guide. I want to note that this little graphic I'm using does not come from the paper. I actually created it because I wanted to use it. But I acknowledge that it distills and boils down what's in the paper in ways that may not be consistent with the authors of the paper. But I've tried to just summarize and describe the 5 tasks that are described in the paper, and to note that there are other tools that come from implementation research that can be used in each of the steps. And finally, I'm not going to spend time in this discussion about this, but just note that stakeholders are involved in every one of these steps in different ways. And there's possibly another type of framework that's emerging, and that has to do with stakeholders, their engagement, planning for their engagement, and so on. So the steps in implementation mapping are described as tasks, as I said. The first one is to conduct a needs or asset assessment and to identify the individuals who are adopters and implementers in the context in which you're working. So that's summarized in this little graphic. And I think that there's a lot of work embedded there, but it sort of blends in, and this is a place where there can be a lot of iteration back and forth between steps and tasks. It's another piece I want to just mention and stress a little bit, that even though this may look like a linear process model, it in fact embeds nonlinearity within it, because there's an expectation that you don't finish a task and then move on. You often have to go back and forth from one task to another to be able to complete it, to make sense of it, and to be comprehensive. So the second task is to identify the adoption and implementation outcomes. And I just want to note, this is where stakeholders become really important. To do that on your own or in your research team or your practitioner team without the key stakeholders participating in this often leads to significant failure. But you identify the objectives that you're trying to achieve, and going back to the definition I gave at the beginning, what is the behavior change that you're trying to instantiate? What are you trying to get done here? And then to assess the determinants. And this is where a determinants framework becomes really important. You could put the CFIR in here, you could put the theoretical domains framework in here. There are others, but the consolidated determinants frameworks are the ones that I would choose. And I'll talk more about that in a couple of minutes. Then we move on to the next set of tasks in this process model, choosing methods, and in the case of implementation, selecting implementation strategies. And here I've just got a little graphic from a paper by Tom Waltz, published in 2015, that did concept mapping and clustering exercise with stakeholders of the ERIC strategies that were, excuse me, developed through the ERIC project. And those papers are part of your background reading as well. So you select strategies, hopefully using a structured process, which I'll talk more about in a few minutes. You then produce your tools, which may be protocols, materials, manuals, a number of other things. And actually then this is the step in which you do implementation. It doesn't say that, but that's what you do, because then you evaluate the outcomes of implementation. And that's where the evaluation frameworks become really helpful. So to summarize process models, they offer suggestions. I would not advise skipping steps, although sometimes you might skip ahead and then come back. non-iterative or non-linearly as you iterate through this work. But these are suggestions, and you're going to have to adapt them to your specific problem, your specific work, and the context in which you're doing them. The steps are broad, so there's always a lot of other planning that has to go into creating a fully developed protocol for using the process model that you're using. And I would just note that these are not consolidated models in the same way that the determinants frameworks I'm going to talk about are, but they come from considerable experience doing implementation or improvement work. And the query roadmap in particular actually is a consolidated process model that attempts to pull together literature across implementation research and quality improvement and describe the steps that those process models embody. So it's kind of a meta guide or a meta process model. So now I'm going to move on and talk about determinants frameworks. The purpose here is to design and sometimes tailor implementation interventions. And I'll talk more in a minute about what I mean by an implementation intervention as distinct from a strategy. First, I want to just get an important set of concepts and terms on the table. There are a set that I've listed here of consolidated determinants frameworks. This is different from a determinants framework that emerges from a single project or a single program of research that might be set in a very specific context, like inpatient units in a hospital or something like that. The first of these was published between 2005 and 2007. Tricia Greenhalgh in the United Kingdom was the lead on this, and they published both a very long 70-plus page Milbank Quarterly Review paper and a book. The book is actually much more accessible and easier to read. It came a little after the review paper. But they reviewed and consolidated components of determinants, elements that influence implementation success or failure across not only health service organizations, but also social service organizations. So this is an extremely extensive, very broad and overarching view of the literature from the mid-2000s. At around the same time, a group of health psychologists in the UK, led by Susan Becky and her colleagues, which also included health services researchers and implementation scientists, did work taking behavior change theories at the individual level and consolidating those into what's called the theoretical domains framework. So I encourage you to look at this carefully. There's a paper published in 2005 that describes the initial consolidated theoretical domains framework, which had 12 domains and a very extensive number of constructs within those domains. And then another paper published in 2014 that updated that framework and added 2 domains to it. So it now consists of 14 domains. Many of you will be familiar with the Consolidated Framework for Implementation Research, which Laura Damschroeder and colleagues here at Michigan developed and published in 2009. It is largely built off of the work of Tricia Greenhalgh, but it incorporates other frameworks and models as well. And then in 2013, Senior Flotorp in Norway and colleagues in Europe and the UK published a tailored implementation for chronic disease checklist, which was actually work done for a much larger European Union funded program of research. But this checklist consolidated over 12 different models and frameworks. And the reason that I think this is important is that it included the Greenhalgh, it included the TDF, and it included CFIR, as well as several others. And I think that it is the most recent currently published consolidated framework and that pulls together determinants across the literature. It was done for a very specific purpose, which is kind of true for all of them, that it was focused on implementing evidence around care for chronic diseases in primary care settings. So for example, in the ICU, there are elements that don't work very well at all. There's very little about teamwork because primary care, certainly in the European countries where this was being done, had less teamwork than we see typically in an intensive care setting. But it still represents the most recent and the most systematic consolidation since the Greenhalgh review in 2005. But I also note that it is almost 10 years old as well. The CFIR is over 10 years old at this point. The TICD is almost 10 years old. And so these are all dated. New evidence has come forward. There are a lot of new things in the environment that are not necessarily included here. And I just want to briefly talk about the naming issue. Is this a checklist or is it a framework? And it depends on what you think you're going to do with it. If you're focused on assessing barriers and facilitators, determinants, to implementing specific evidence-based practices or programs, using it as a checklist can make sense. We typically collect data using any of these frameworks, using qualitative semi-structured interviews with an interview guide. And I also want to note that the TICD in particular, although this is true of Greenhalgh as well, includes both individual and organizational level determinants. The CFIR does to an extent, and the TDF does to an extent. TICD uses both of these, and I think brings together some of the most important elements from it. Not all elements of any of these are included in the TICD. Decisions were made to leave some things out. But nonetheless, it gives us a framework to use as a checklist to go through and think about, are these elements relevant in the work that I'm doing? So very quickly, I'm going to go through each of them, mostly to give you a little bit of the picture for each. This is the Greenhalgh. There are 9 domains and 41 major constructs within these domains, but each of these constructs is very complex. And if you look at this carefully and think about it, you'll see similarities to all of the frameworks that followed it, except the TDF, because the TDF was actually developed at the same time without any cross-pollination between those two efforts. Another comprehensive framework is the TDF, which comes from a very different space. It takes 33 different behavior change theories in the health psychology literature, basically deconstructs the theories and puts the constructs into a set of domains. And the 14 domains are over here. This picture is actually the behavior change wheel, which is another thing that Susan Mickey and her colleagues developed slightly after the TDF was developed, that kind of groups the TDF even more from the 14 domains into a smaller set, and then really gets you to focus on issues of capability, opportunity, and motivation. This whole set of work can be linked to what's called the Behavior Change Techniques Taxonomy, or BCCT, version 1.0. And I've given the citation here. The primary focus of this work is on individual attributes and cognitions. And so it depends on what kind of work you're doing. If you're thinking about changing prescribing behavior, the TDF might be the most relevant thing to use, even though there are organizational constraints that operate on prescribing. But much of the work is about individual decision-making, and the TDF gives you a lot of information and a lot to think about there. And then there's the CFIR, which is the shortest and smallest of all of these determinants frameworks, consolidated determinants frameworks. This is the picture that most people are very familiar with. It has 5 domains, 26 main constructs and 13 subconstructs within those main constructs. And it offers a lot of utility. It has its strongest focus is in the organizational side, with a very brief look at the individuals. And I would argue that it has a lot of use. I think the organizational focus can be very helpful. So my question then is, given all that, why not use the most up-to-date consolidation, which is the TICD? Again, there is no graphic in the paper, which is cited here. So this is a graphic I created, but I did run it past the authors who felt like it was a reasonable representation. It is the most recent consolidation. There are 7 domains, 57 constructs within these 7 domains. So I just want to note all of them have a lot of stuff in them. And remember my criterion of accessibility. For a lot of people, CFIR is more accessible. It has the cfirguide.org website. There's a lot of experience with it. It's extremely widely used. And I think it has a lot of appeal to it. But it's not the most current. And the smaller number of constructs actually may be both a positive and a negative. The positive side is there's less that you have to think about. The negative side is it misses some things. And I think that that's an important issue. So how comprehensive is the determinants framework that you're thinking about? How much does it cover? How important are all these issues? That actually is a question that has to be resolved with study by study, because the importance varies from context and problem and characteristic of an innovation or intervention, widely. How important are individual versus organizational attributes? This, I think, is a really important question and criterion to use as you make a selection of determinants frameworks. How much do the organizational constraints matter? And how much is being driven by individual decision-making? Again, this will vary from study to study, which is why I don't think that it makes sense to say, well, I'm always going to use the CFIR or the TICD. Sometimes you may want to focus more on the theoretical domains framework. And sometimes you might want to go back to that much larger, more comprehensive work from Greenhalgh. How recent it is important because things have been changing, especially in electronic data, digital interventions, a lot of things that are not included in any of these frameworks at this point. And then what setting was it designed or developed for? Important to keep in mind, almost all of them are largely based on primary care and outpatient settings because that's where most of the work in implementation research to date has been done. There are others that are included in the Tabak et al. Review that do cover different settings. So I would just offer these as criteria for you to think about as you decide if you're doing implementation intervention design to use one of these determinants frameworks. Very briefly, how do we use the framework? This is actually a point that is still very murky, and I would say it's not settled, but a paper that was published in 2020 by J.D. Smith and his colleagues, a very brief citation is here, but I think I gave you the paper as background material. The purpose of the determinants, and this is a bit different from what's in the paper. We reworked this for some work that I've been doing. This actually includes no, this is actually the CFIR. We did one that includes the TICD. And so I'm sorry, this is the figure from the paper. So in this, the determinants from the key constructs from each of the determinants using the CFIR are entered into the boxes here. And then you think about the strategies. And this is where it becomes important to think about a typology of strategies, like the ERIC set of strategies or the EPOC set of strategies. That's a different discussion, and I won't go into today. But again, there are choices to be made there about how do you find a set of strategies to begin to select from. The big issue here is, what is the mechanism of that strategy? How does it work? And the question there is, what's the causal mechanism for the determinant? Why does it exist? If it's a barrier, a negative determinant, then why does it exist? Why is this in the environment, and why is it causing a problem? Figuring out the causal component to that, thinking about this in a root cause kind of way, helps you to say, okay, here's the root cause of this. Here's a mechanism of action for a specific strategy or set of strategies. If these two things line up, then I should be thinking about selecting strategies out of this group of strategies or this single strategy. My point about implementation interventions is that after you've selected hopefully a parsimonious and small group of strategies that will overcome the majority, at least theoretically, overcome the majority of determinants, negative determinants in particular, and use the positive determinants that you found, that you can actually then take those mechanisms and you can say, this is the reason that I'm going to use this strategy to overcome this barrier. if you have more than one strategy, and generally we do when we design work and implementation, putting them together into an implementation intervention and considering the possibility that you might also use behavior change techniques from the behavior change technique taxonomy gives you a much more powerful set of tools to think about how to put all of this together and design a cohesive and comprehensive implementation, intervention, and approach. So I will stop talking about that there, but just to say that this is kind of the payoff. This is why you've been using a process model and then, determinants frameworks. You need to get to this point of designing implementation interventions, which you then enact and put into place. So the last thing I'm going to talk about, and this will be brief, is evaluating what you've done. And this is the role of evaluation frameworks. So there are two primary evaluation frameworks in the literature at this point. There are others, but by and large, these two are dominant in the literature. They are very flexible. That's one of the reasons that they're dominant. And they're also, they make sense to people. So the first is REAIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. It's been in the literature for well over 2 decades at this point. It has been used in literally hundreds of studies and published in papers. And there, in fact, are a couple of systematic reviews at this point. I would encourage you to look at all of those. They're cataloged in the reaim.org website, which I would also encourage you to visit because it has some very helpful, useful tips on how to use REAIM. I'll also say that REAIM was initially designed for health promotion work, which again focuses much more on individual decision-making, the decisions that individuals make about smoking cessation, about adherence to medications, activity, diet, all of those kinds of things. So using it for implementation and thinking about that definition of implementation I gave you, which is human behavior change, including individuals, under organizational constraints, the organizational constraints are not as clear in REAIM. I think this is one of the reasons why the Proctor framework or the implementation outcomes framework, which comes from this paper that was led by Enola Proctor, published in 2011, is appealing to people because it actually calls out implementation outcomes specifically, which most of the outcomes in REAIM are, and divides it into things that are really tightly linked to implementation versus things that matter to the organization, and then things that matter to the client. What's kind of missing here is the provider. And this may be because this work is largely grounded in community mental health, behavioral health organizations, which is where Enola does her work. And many of you may be focused there as well. And the provider side of things tends to be a little less clear in some of those organizations than it is in, for example, hospital settings where I do a lot of my work. So I just note there are some missing pieces. And when you use either of these, because these are so flexible, you really have to make sense out of each of these terms. What is acceptability in the context of the work that you're doing? What is adoption in the context of the work that you're doing? And so on. I also just want to quickly note that this paper actually pulls this out of a much broader framework that was published in 2009 that I think in some ways helps to make more sense of it. And while I think the paper stands alone, I would strongly urge you to find the 2009 paper and review it as well, if you plan to use this framework for evaluation. And so just very briefly, what are we trying to do with evaluating implementation is to understand what happened as a result of implementation, not necessarily what happened to patients or clients or the ultimate end user. Did their outcomes change? Did they survive better? Did they did they have better hemoglobin A1C? Is their mental health better? Are they using substances less? Any of those things are sort of outside of this focus on implementation outcomes. Very important though, and I wouldn't lose track of them because ultimately the whole purpose of implementation is to affect those end user outcomes. But to understand whether the implementation itself was successful, you really need to think about some of the outcomes that are cataloged here. What processes changed? What behavior changed? So I just want to call out that there are some measurement instruments that were designed for the implementation outcomes framework, the Proctor framework, which we just talked about. One that focuses on acceptability, the acceptability of intervention measure, or AIM. One focusing on appropriateness, the intervention appropriateness measure, IM, and one focusing on feasibility of intervention measure, FIM. The citation is here. These are they're basically 3 questions in each of these short instruments, and they really have to be contextualized within your own study. I think the jury is still a little bit out as to how useful this is, and particularly when to use it. And I just want to call your attention to the term intervention here, because that is actually a very, very ambiguous term in implementation work. There's both the intervention, the thing you're trying to implement. That language comes from Jeff Curran in a paper he published in Implementation Science Communications, which briefly has a sort of a teaching slide in it. That thing, if you read the Weiner et al. Paper, you'll see that that's actually what they're talking about. It's acceptability of the thing that you're implementing. But there's also a question of acceptability of the way you're doing implementation, the implementation intervention as well. And so I would just note that all 3 of these operate at both levels. And you might want to think about measuring at both levels as you do your work to make the most use and sense out of these. So I'm essentially done, but let me just summarize what I've gone over because it's a lot of material. Even though there is this proliferation of frameworks, well over 120 at this point in the literature. And I also would just note the systematic review that Rachel Tabak led was published over almost 10 years ago as well. So again, it's dated. There's more than there was when they first looked at the literature. I would argue that you can use criteria and principles to make sense of and use these frameworks for the purposes that you need to use them. So understand the function of the framework. It is unfortunate that at this point, these frameworks are not tagged. They're not actually labeled with what type they are. I've done some work around that. It turns out that many of them are kind of hybrids, that few of them actually fit neatly into one bucket or another, but they tend to have predominance in one type or another. Understand when using one type is more useful than another type. So trying to use a determinants framework to do process work, frankly, doesn't make sense to me. But using a process model to do determinants work, to design an intervention, an implementation intervention, also doesn't make a lot of sense to me. And yet I see people trying to do that all the time. Among the frameworks, and especially among the determinants frameworks, there are some criteria that I've given you that I would argue are important to help select which one of these you're going to use. And from my perspective for designing implementation interventions, I would argue that determinants frameworks are the most useful, critical piece to be able to actually do that systematically and to build on the literature. But you may not simply be focusing on designing implementation interventions. You may be doing other things. And so think about what you're doing. Think about the use of the frameworks, what their purpose is, and what you need them to do as you decide how to use them. Thanks.